So do you think we'll be going to the day that we're talking about diversity, and if you are checked and have low diversity, we'll be given a new spread of bacteria to take for a week or two?
Well, I think if you find me someday talking to my microbes, you'll know that I've definitely lost it completely, and this whole thing has got to my head completely. I don't know, but I do think there's plenty of grounds for minding your microbes.
Oh yeah. So, you know, as I ended the talks this morning with this concept of a paradigm shift, instead of killing bacteria, we're not going to be giving bacteria, but it's going to take a lot of work. Do you see the day, do you see there will be, you know, what's the biggest place you think we can affect right now, today in 2015, we can make a difference with our probiotic strains? What disease state or condition?
I think it's having targeted therapy. So whether that's whether the right option is having a single strain for this condition or having a multi-strain for that condition, it's having increased knowledge so you know what to recommend, and that it's evidence-based. So it's not this generic recommendation, oh, you know, take this, you know, take a probiotic. That's going to be a defunct term. It'll be take Lactobacillus salivarius UCC 118 for barrier function.
The realm of obesity is probably the most fascinating and might be, I would imagine, pretty impactful. And from a clinician's perspective, we see these patients coming into our ICUs and many things happening to them. We see them in the outpatient setting, and they don't recover as quickly. And if we could have targeted therapy for obese patients, I think that would be pretty incredible.
Targeted therapy is a nice way to put it.
Yeah.
Yeah, I think the grand challenge is to ultimately control precisely what the composition and behavior of the microbiota is in our bodies, and that'll have most relevance at the extremes of life. And extremes of life don't just mean extremes at age, very young, very elderly. It includes the people who are very stressed, such as in the military. It includes athletes who are pushing their bodies to the limit. So in those situations, we should be able to control that. Now, we do it to some degree with fecal transplantation, but that's still quite crude. We're very close to actually having artificial stool where we'll define exactly what combination of microbes we want to be transplanted. And that'll have safety benefits, of course, too, but it'll be the optimum. And it might differ for one individual as opposed to another. So we might have to design our fecal transplants. But the biggest area will probably be at the point of birth, to control the way we're colonized. We already vaccinate for pathogens in young children. Yeah. We may well do the same for commensals, for normal microbiota, expose them to the ones we want them to see.
What are our barriers to implementation of the use? You've already mentioned it, is we have a lot of information and we don't know what the targets are yet in many cases and what the endpoint we're watching for. I think that, to me, is going to be one of the biggest problems, is what are our markers of success? You know, what are we going to use as a surrogate marker? Is it the change in flora? Is it the reduction of disease state? Is it decreasing risks for future diseases? So I think finding some objective outcome parameter which we can follow may be very difficult to find if we're giving either a single species or multiple species. It'd be okay for a disease state prevention, but it's going to be tough to look at for the general population.
I think there's so much information and it's confusing, and to try to translate that to patients or consumers is really complicated.
I think the consumer is very hungry for the information, but we don't want to give false information without some objective measure and data.
Well, I think the greatest barrier to the rational use of probiotics is the assumption that they're all the same.
Yeah.
And I think the greatest barrier in the long term for working with the microbiota and trying to optimize it is that everything we do in daily life, in modern living, is actually having an adverse effect on our microbiota. Sedentary activity. Exercise seems to be able to promote a diversity. So almost every aspect of modern living is actually having an adverse effect on the microbes that colonize us.
New biomarkers will emerge, So diversity is almost now becoming a new biomarker because of its, you know, it
Diversity
correlates.
itself.
Yeah,
Diversity
diversity
itself.
Right.
And it is measurable.
And when it's cost effective to do that, you might go, oh, you need a little more flora.
Exactly.
Yeah, oh, listen, you're a little low here. Let's just get you back up.
Well, and like it is you know, like a shift in diet, maybe
Yeah.
what's needed, or, you know, an increase in exercise. I think there's a lot of studies out there about the link between low diversity and outcomes, but actually there's very few that actually have shown how to promote diversity.
Yeah, or high
besides
diversity,
diet and
improving
exercise.
And I think it's a better narrative than the one about this rise in antibiotic resistance, telling the world that we should stop using antibiotics for a flu, for a virus, telling them that we got have new prescribing practices by family doctors, that they're abusing antibiotics and overusing them, and the same in hospitals. That's like talking about the polar ice caps. They're melting, and the politicians deciding that we'll set some deadline to fix it, you know, when I'm no longer in power, 10 years later perhaps.
Right.
It's just not working. But if you tell the consumer that, well, you know, you're damaging your microbiota, they get that, they understand that. They understand that maybe that's partly contributing to the rise of allergies and the rise of obesity, particularly in childhood. Then I think the consumer would be less demanding to take probiotics for things that they don't need them for.
I think a challenge will be as well is developing practical guidelines. So let's say in the clinical setting, you know, the healthcare professional knows exactly in what to recommend.
Yeah, well, you know, in our 2015 critical care guidelines, which will be out hopefully in a month or two, it's at review right now. The U.S., these would be the U.S. guidelines, so to speak. We say we should use them, but only in case where we've got random, but we don't give specifics.
Yes.
You know, because it would be, the
Exactly.
document would be too hard. So, but we certainly recommend the use in the acute care setting. Well, is more better.
More isn't better.
Right, exactly. See, I think we
Not
got to be careful.
necessarily,
I
no,
think there's a
no.
dose response, and if you overload with one, you may then cause decrease in your others. So I think we've got to be careful with dosing.
Well, there's also the assumption that 2 capsules might be better than 1 or 3. We think of drugs in that way, that we might double the dose. But keep in mind, bacteria measured in log folds, you know, 10 to the 9, 10 to the 10. Taking 2 only increases by 2 by 10 to the 9, 10 to the 10. That's a tiny increment, whereas they go up in tenfold. So taking 2 capsules usually is a waste of time. And people need to know that these things are measured, and when you consume these probiotics, these bacteria, they do multiply in the gut, and the gut has its own controls. You don't have to take billions and billions and billions. You just have to take enough that gets established and that you get into steady state. So more is not necessarily better.
That's an excellent way to look at it.